So a quick revisit. Here our beautiful mnemonic. So along the pinky, here comes the thumb. So starting with 1 to 3. Then there's some confusion on 3 and 4. Is that pisiform? You can't see it particularly. Pisiform is this little projection that sits on top of triquetrum. Triquetrum. Yeah. Make sure I'm saying all these right. It sounds like alien stuff. So you can actually only see it from the palmar anterior side. So I'm holding it right now. That's pisiform. So pisiform on top of triquetrum, and then you're going over for the rest. For hamate, capitate, trapezoid versus trapezium, D before M, alphabetical order. Try for 3, you're on your way. And then as long as you remember the mnemonic, the beautiful thing about most tests that you will be in is you won't be in a position to have to like sit there and spell these out, right? You need to know that there's an S and an L. So start there, being able to recognize the mnemonic, the bones by looking at lots of charts and pictures and quizzes, and then I promise you'll just come in. The next one.
Your screen wants to see.
Oh, yeah, it likes to do that. Wake up. Now, in general, we've talked about the torso, and as far as the axial skeleton is concerned, the axial skeleton includes the skull, the spine, and the ribs. So what here is not part of the axial skeleton? Yep. The pelvis is not part of the axial skeleton. The scapula is not part of the axial skeleton. So the pelvis, the ilium, and the scapulas are part of your appendages. So is the clavicle, since that's what actually attaches your scapula and your arm to your body anyway. As far as the appendages are concerned, though, things are quite similar, right? Even the axial skeleton, you have this big thing on top, and then I guess the only comparison you have there is your tailbone, your sacrum.
And it's the vertebrae.
So then you at least have correlating mobile vertebrae. So cervical spine, lumbar spine, and then the big cage for the thoracic spine and the ribs. Housing all your organs, cardiac and breathing, plural stuff up here, got everything else down there, and separated in their cavities, all that good stuff. Beyond that, aside from our clavicles, what you have is an elephant ear shaped thing, long bone, two bone, little bones, digits. The framework from one limb to the other is incredibly similar. It's just that with us, there's a much larger adaptation for stability versus mobility. So bigger stuff with the capacity to undertake more weight load versus more delicate, more mobile, but not nearly as, it's not built for standing on in the same way. We don't have to worry. Obviously the humerus, the femur, and the radius, and the ulna to the tibia and fibula. There's only a few differences, and then like the fibula is not as mobile. It's fixed for the most part, but there's a little wiggle room compared to this radius that can completely flip over. You have a patella down there as opposed to the olecranon, big projection bone here, both of which you can palpate, Then once we're to the little bones, now we have some memorization tactics. And in terms of the digits, we've covered this some, but your thumb or your big toe is number 1, and then it goes out to 5. So thumb, big toe, 1, then your indicus, 2, middle finger, 3, ring fingers 4, pinkies 5. And even the metatarsals or metacarpals are numbered the same way. So those aren't too bad, right? Then it's just getting all these little bones out of the way. And I honestly struggled a little bit more with the carpals just because they were ones that I didn't palpate and manipulate as much. I kind of think of them on a practical sense more like as a group. And then the foot bones are what I far more often actually fixated on. And you will tend to see this, that there'll be, unless it's, as I said, the common issues will be related to a fall where something occurs here, but issues with the ankle and the tarsal bones and how they function relative to the arch of our foot. I mean, there's so many codependent actions that have to occur here. We've looked at some gait functioning, and since weight bearing, then there's going to be a bigger effect when there's something off in your foot than there is obviously when it's going to be in your hand. As a massage therapist, then you're going to be in a category where if you're bearing weight on your palm, that can be difficult, which is where also you really need to get good at using your forearm, right? Now this isn't, I personally didn't really use a mnemonic as much here, just enough coverage of this, eventually it sank in, but this is at least an option. Talus covers navicular, navicular covers cuneiform, so you're still memorizing in this 3, and then you're introducing the extra C's to represent cuboid and calcaneus. Let me pass around in reverse order a leg and a foot. See how crooked our toes are. That one flopped really.
It needs some stability, doesn't it?
So, what actually makes up your ankle joint? A little bit like when I was talking about with the wrist joint, it's scaphoid and lunate. Here, just one tarsal bone actually makes direct contact with your tibia and fibula. It's mostly fibula. Mostly it's the tibia. But talus, you can see this one right here. That's the one that is on top of everything and makes direct contact. Calcaneus, the one that you feel the most easily, right? When you grab a hold of somebody's heel, that's that one. And yes, it's by far the biggest, but it is not the one that becomes part of the ankle joint proper, right? Talus sits on top of calcaneus. And naturally, if those two aren't happy, then, you know, ankle's not moving good, arch of the foot won't be moving good, and it'll just translate up the whole body in that kinetic chain form that we've looked at. One thing I want you all to look at as you're grabbing hold of this foot is once you can, identify talus, identify calcaneus, and then look at how they articulate with the rest of the tarsal bones, okay? You'll be able to split the foot almost in half. You know, it's 5, so we can't quite do that. But the 4th and 5th digits make direct contact with just one bone. Okay? They share cuboid. And cuboid makes direct contact with calcaneus. This is the lateral side of your foot. So when we kind of heel strike, and there's a little bit more weight carried over on the lateral side of the foot, this is all about extra stability. Even the protuberance of this distal end of the 5th metatarsal is really big. And that's the pinky toe metatarsal, but it's this huge extra bunch of bone to allow for extra muscle attachments. So the lateral side of the foot is all about stability. Then you come over to the medial side of the foot, what we always call the arch, at least when we're looking at the plantar side of the foot. And we have talus meeting with navicular, which then meets with 3 separate bones that contact the additional 3 separate metatarsals. So the big toe, the second toe, and the middle toe all meet their own individual bones. There's a lot more mobility over here. And this space in between, the lateral, third versus the more mobile medial third, or 2/3, is one that I stress is essential. That we need to have this stability to allow for the weight load and impact, but there's a lot of translation of forces from your first and second toe predominantly as you walk. As I have a good, nice walk, I would like to think, my big toe and those little toes need to allow for that. Now all the toes do, but it's really these first three that need to really allow to go into extension for that, okay? Then right here we have this whole 4-bone relationship that occupies what we think of as the arch, meeting the bone that makes up your ankle joint. One way to conceptualize this with some common physical distortions is that somebody with a high arch has their foot permanently what we call supinated, but those bones are up higher. Maybe like I'm doing this, trying to lift that up, like that. So high arches, having high arches, there's too much space here. Versus a flat foot, a flat person with flat feet, all these have dropped. And it's like me doing that. So there is pronation and supination of the foot, but it's not the same way as it's talked about here in the hand. But that's why it can be problematic for people that have either one of those two things. Really high arches or flat feet can lead to a lot of issues regionally, but up to the whole body. A common thing will be that people with flat feet don't do well with running, but there are people that will surprise you. I remember seeing the flattest foot I've ever seen, and it was a 7-foot center that never got hurt in, I think it was, well, there was one small thing, but for years, did fine. And it was a back thing. It wasn't anything here. He was built differently than some of the big men, like kind of had more like tree trunks for legs. He was built more like a brick as opposed to an upside down triangle. Upside down triangles don't fare as well, right? But that flat foot, his feet were always sore, but boy could he run. So you can't always make assumptions, right? The body will adapt. But that division, anybody taking that foot, you can see how you can split that. And then think about that in the context of when we work. That it's important to not just work on the arch of the foot, and how if we're going to have an effect on these, we can get a hold of these in a more specific and profound way than we can the carpal bones. These we have to work on, like it's to try to work on an individual carpal bone is going to be quite silly. You're going to be usually using like what I've shown, like a soft fist or a palm, to move them all and get those sliding joints to be able to shear and shift. Here though, I mean, you can, with multiple positions, do a good job. One being in prone, that's where grabbing hold of that calcaneus, stabilizing that, and then moving the rest of the foot is a nice general way to create pliability between it and talus, it and cuboid. So it feels nice, pressure directly here. There isn't, there's some extra tissue, but there's not a muscle or anything right there. This is for shock absorption. So it usually feels better for people to just have this squeeze rather than pressed on directly. But if we do that, give it a squeeze either from this way or this way, and you see me tend to do that both. I'll grab it like this, and then grab over here and do a little back and forth. And then as I walk around, I'll grab it like this and bend it back and forth. And that's going to create some nice general mobility relative to calcaneus and everybody else. In sideline, that's where working across the top of the foot, the dorsal side of the foot, is one, it can feel really good, but it's about creating this division in my mind. That's what I'm thinking. I'm seeing this line that separates the last two toes from the rest of the toes and keeping that pliable. That tends to look like this hand underneath, right, with that claw into the arch of the foot so it feels good. And then this hand on top, and then back and forth. Maybe a little bit of a glide depending on how much lotion you have, but if these fingers are stabilizing as much as possible, and I could work my way down and be precise, but usually I'm trying to be somewhere right there, you know, right in line with the middle toe. And by holding that and just doing a nice massage back and forth, they're gonna have this point pressure in the arch of the foot, which is more sensitive, what people will tend to find more enjoyable, all that. But then we're getting the added value of just creating this little back and forth action that's gonna keep these bones moving like they should. And the muscles in between, secondarily up here in the metatarsals, will get bent back and forth. And that will keep them pliable and unstuck. The hands and the feet tend towards getting stuck, and then So think the toes tend to get crunched up on each other, right? So there's your visual, ultimately. And just where, and obviously, you know, side lying on either one of these. That top foot is one that I think gets missed the most, but right here, that's where also what I'll do is stabilize under all those metatarsals and then bring that forearm in. And then as I apply, massage through this hand is causing some stability on all the metatarsals, and there's getting all that nice action back and forth. The only other thing that you could consider is, you know, somebody's laying prone, can bend their foot like this. Find the main bony landmarks that create the ankle joint. So you won't call this just the tibia or this just the fibula, it's part of it, but these are the malleoli. So lateral malleolus, medial malleolus. Two different bones, but named like similar bony landmarks, okay? In the wrist, it's styloid processes. Same concept, different bones, but same names. So medial styloid, lateral styloid. They're just little bony projections to stabilize and hug those bones. Now obviously those are a lot smaller, but looking at the design here, look how the fibula is that lateral malleolus is much bigger than the medial one, right? So that keeps the ankle, for the most part, from being able to evert. It's more inclined to, because of the structure of the skeleton, to invert. That's why ankle sprains tend to go that way. And then those ligaments will get stretched, and there can be a whole cascade of things. But just structurally, that's why. It's meant for a good reason, but that's why some injuries will be more inclined to others. It's just because of the nature of how we're designed. That talus, though, can get jammed, and rather than, you know, we're never popping joints or making that our goal. Somebody's laying prone, I bend the leg, I find the malleoli, the lateral medial malleolus. I don't want to be down here. That's not doing anything to the ankle joint, right? I have to use those bony landmarks to guide me. So I'm like this, and then just squeeze and move that ankle back and forth. Right now, I mean, it'd be amazing if I could make that happen. That's not what's going to happen. It would look like this. In supine, I'll do that too. I'll grab that calcaneus, find those the malleoli, and then just kind of move the ankle back and forth. Not trying to cause like some kind of big shift, just creating a little gap here and trying to tell the talus, hey, let everything slip and slide. And maybe if a shift does have to happen, sometimes it does occur, but that's the way that gets affected, by using those bony landmarks very least, good squeeze. You could lift, that's more effort. I tend to do something that looks more like this. Person's laying supine. The one thing that I do on the foot in supine, I never massage the foot in supine if I can help it. I just grab hold of calcaneus, find lateral malleolus, medial malleolus, give that all a nice squeeze, and move that ankle back and forth. It can be real small and gentle, but it's creating that slip and slide for each of those little joints, all of which need their WD-40, like anything. There's the anatomy. Done.
Ah.